Thank you for having me. So I was asked to talk about what's next in Hodgkin lymphoma. Would we get the slides here or? Okay. So these are my conflict of interest. As you know, Hodgkin lymphoma is a frequent lymphoma in the kingdom because it's a disease of the young people, and the kingdom society is a young society, basically. It has bimodal incidence, but frequently we see only the young patients in our clinics. So we went through a long way in the treatment of Hodgkin, starting from, in the 1960s, extended field radiation therapy. Then the radiation therapy field was reduced and without compromising the results of the tumor control. Then combined treatment, chemotherapy plus radiation showed better results and became like a standard for early stage patients. Chemotherapy also improved. This is a paper from the 1970s, 1975, comparing MOP to ABVD. Same efficacy, but much less toxicity with ABVD, so ABVD became standard of care. Then, because of the high curability of this disease, the focus became on how to decrease the long-term side effect. Again, this is a disease of the young, and infertility, second cancers, and MDS are problematic for this population. So next came the PET-adapted approach or response-adapted approach, and we had trials done in the early favorable, as you see here, early unfavorable, as well as advanced stage. So basically, you reduce your treatment depends on the response, or you increase it, and by doing this, you spare around 80-85% of patients from aggressive treatment, because it is expected that around 80% of patients will have negative interim PET scan. Novel agents also were introduced. First of all, they were introduced in the relapsed refractory setting, post-auto relapse or regular. Here you see the nivolumab phase 2 trial. Here's the pembrolizumab trial. And then recently, brentuximab got approved in the frontline setting based on the Echelon-1 trial. So also we got to learn that maintenance can help few patients with high-risk features post-transplant. So this is also something new in the treatment of Hodgkin lymphoma. Based on the ATHERA trial, brentuximab was approved for patients at high-risk features for 1 year maintenance post-transplant. Pembrolizumab and nivolumab actually are being studied in phase 2 trials with very good results so far, but still they don't have a label in that indication. So the next questions, one of the next questions is, would immunotherapy become a standard, pretty much like antibody drug conjugates became a standard in the front line? And this will be answered from the 1826 trial, SWOG trial, which compares Nivo-AVD to Brentuxi-AVD. We have seen the prelim results in ASCO, and there is a progression-free survival benefit, 94% versus 86% at 1 year, statistically significant, but no overall survival benefit over this short period of time. Here you can see that all the subgroups did benefit, and the good thing about this trial, it included patients starting from the age of 12, actually, so pediatrics plus adult. And here you can see the death reported in this trial, 11 deaths on the AAVD versus 4 deaths on the Nivo-AVD. So with time, probably the overall survival will be demonstrated, but we just have to wait for these results to mature. The other question is, can we use both antibody drug conjugate plus immune therapies in the frontline treatment? And this trial is for treatment-naive patients combining BV, Nivo, and AD. So It has three parts. Part A is for stage 3 and 4. Part B has stage 2A bulky, 2B, 3 and 4, and part C for stage 1 and 2 non-mediastinal classic Hodgkin lymphoma. And as you see here, we have results on the part B. So part B again is the 2A bulky, 2B, 3 and 4. And as you see, they had median follow-up of 18 months, and at 18 months, the progression-free survival was 93%, which is pretty good. CR rate 89%, peripheral neuropathy is 44%. So we'll have to wait and see if this combination also becomes a standard in the future. The other question is, could we de-escalate the treatment or change the treatment to antibody drug conjugate and immunotherapies after initial assessment with PET? So this is a trial for early stage patient, favorable and unfavorable, where they start with ABVD after 2 cycles PET scan like our routine, and then there they will randomize patients. So PET negative will be randomized for more ABVD versus BV-NIVO only. So in that scenario, your patient would get 2 ABVD and 4 BV-NIVO only. And then for PET positive, also they will randomize for escalated BIACOP versus BV-NIVO plus involved site radiation therapy. So this is also important to know. That way you can spare your patient from a lot of toxicities. I put this in the next questions because we just don't have phase 3 trials on the combination of BV and NIVO or Pembro with salvage regimen. So we use these pretty much routinely on the majority of patients, not all. So when we salvage patients at high risk, we add BV or checkpoint inhibitor. And that's because by doing so, we increased the CR rate. We almost doubled, the PET negativity rate. And it's well known when you go to transplant with PET negative, the results are way much better than PET positive. So this is why we do these combination in specific subsets. All this is based on phase 2 trials. We don't have phase 3 trials. So this may be answered in phase 3 trials, and we'll see. Now, one of the major questions, very important question, do all relapsed refractory Hodgkin lymphoma need auto-transplant in second line? We all face patients in our clinic where you treated them 10 years ago, the disease is back now, limited, and then the question is, should I take this patient to auto-transplant, or can I do something else? So this is a trial here that started the Pembro GVD trial, salvage. So they started this trial with the intent to transplant, and they saw very good efficacy with the first 38 patients, 92% CR rate. And then they added a second cohort, and that cohort will help us to answer this question, whether everybody needs an auto or not. And that second cohort, patients will receive Pembro rather than going to transplant. So patient in CR will go to Pembro maintenance 13 doses rather than transplant. To date, a complete remission has been achieved in 88% of these 34 individuals recruited on this part of the trial. So as time goes, we will be able to tell whether these patients will stay in remission and as such don't need autologous transplant. This is another trial trying to answer the same question, different scenario. So here they recruited transplant unfit patients on this trial. So this is elderly comorbidities with their first relapse, and they randomized them for BV-NIVO without subsequent transplant. It's a PET-guided approach, little bit complicated schema, but basically this is what this trial is trying to answer. Does everybody need a transplant, or some people will be spared from transplant? And this is another trial as well. So this trial is doing triplet therapy, brentuximab vedotin with ipilimumab and nivo. So they have 3 arms on this trial. It's still early stage trial, trying to judge the toxicity and the efficacy of this combination. And it seems like the triplet combination is significantly better than the doublet. So BV, Nivo, Ipilimumab. Of course, we need a larger set of patients, and we need to follow long-term to know the efficacy and the safety of such a combination, specifically for the immune side effects. So this is an important question as well that hopefully will be answered in the future. Next is, can we reinforce the activity of checkpoint inhibitors? And apparently LAG3 is involved in T cell regulation and commonly expressed with PD-1 on energetic T cells. So blocking this LAG3 might potentiate the efficacy of other checkpoint inhibitors. And this concept has been demonstrated in melanoma. So this is a trial that was started as phase 1/2 of anti-LAG antibody called favezelimab in combination with pembrolizumab in patients with relapsed refractory malignancies, including classic Hodgkin lymphoma. So here you see the result of cohort 2, and this is the classic Hodgkin lymphoma cohort. And all these patients have failed PD-1 previously. So it's a combination of this anti-LAG3 plus pembrolizumab in patients who were exposed to anti-PD-1 and failed previously. And as you see, overall response rate is 30%, and CR is 9%. However, the impressive thing about this is the duration of the response. So the patients who responded, the 30%, enjoyed 19.4 months of progression-free. So that's the impressive part about it. And this is now taken to phase 3 trial of anti-LAG3 plus pembrolizumab combination. So the same combination was tried in PD-1 naive group. Okay, so the previous group is PD-1 exposed and failed. This is PD-1 naive. Here they saw that the autoimmune side effects are a little higher as compared to checkpoint inhibitors alone. After a median follow-up of 14 months, the response rate is 73% and the CR rate is 27%. And 55% of patients who responded more than 12 months. The median PFS is again 19.4 months. This is another question, maybe a financial question, and I found it very impressive. So this is, when we use nivolumab, we use the dose of 3 milligram per kilogram, and this is just because this was the maximum tolerated dose in phase 1 and phase 2 trials. So it was taken for phase 3 trials as the maximum tolerated dose. But do we need to reach that maximum tolerated dose to have the efficacy? So this trial compared nivolumab 40 milligram flat dose, 40 milligram versus 3 milligram per kilogram, which is the 240 every 2 weeks, okay? So 1/6 of the initial dose, okay? So 2 cohorts, nivolumab 40, nivolumab regular, and after a median follow-up of around 60 months, the overall response rate was similar, 68% versus 67%. Timing to best response is similar. PFS is not statistically different, but in favor of the lower dose, actually, 21.9 months for the lower dose versus 18.8 months for the regular dose. OS was not reached. And in terms of adverse events, they were not statistically significant, but there is a clear less side effect in the Nivo 40 milligram group as compared to the higher dose. So this is very impressive. You can save 1/6 of your cost, 5/6 of your cost by using this approach. The other questions are, what happens when we discontinue nivolumab? This is a frequent question in the clinics. You treat your patient, you treat it for 2 years, and then what? You stop, we don't stop, what do we do? So this is a retrospective trial, looked up at 48 patients who stopped nivolumab. So of these 48 patients, 40 were in CR, okay, and 8 were in PR. So they took the course of nivolumab and stopped. and the 63% of them relapsed, okay? But the median progression-free survival was 43.6%. For patient with PR, the median PFS was 7.7 months. So it seems like some patients will enjoy long progression-free survival. Again, the median is 24 months after stopping nivolumab. Now, if we retreat these patients with nivolumab, what happens? This is also impressive, and it seems like these patients respond pretty much like patients who are nivo naive. So if you see here the second paragraph on the slides, so after 33 months of median follow-up, overall response rate is 73%, and this reflects the efficacy of checkpoint inhibitor in treatment naive, actually. So these are retreated patients. They were in CR and they were retreated. Median PFS is 24 months, so 2 years of PFS by retreatment, just reintroducing the same drug. And at 3 years, a quarter of the patient, 26.7%, were progression-free. So retreatment with nivolumab is a good choice. PET-adapted is another issue with Hodgkin lymphoma. Basically, we use PET to adapt our approach, and we use PET as a minimal residual tool in classic Hodgkin lymphoma because we cannot do flow cytometry like ALL. The Reed-Sternberg cells are not concentrated in the tumor, so you cannot do the same approach as in other tumor. So this is why around 15 to 25% of patients, despite being PET negative, they would relapse because it's not a very sensitive tool, and having PET negativity doesn't guarantee no relapse. So the question is, do we have a better MRD tool? And it seems yes, we do. This question becomes more important actually in the era of immunotherapies because, as you know, when we treat with immunotherapy, you may get flare-ups. So the tumor would light up on the PET scan. However, it may be gone. So you will have a PET positive, but the patient doesn't have a tumor. And now immunotherapies are becoming part of the frontline treatment, specifically with the SWOG 1826 trial. So PET scan will become problematic in these patients. So this is a pilot study that explored APVD. So P is pembrolizumab, so immunotherapy in Hodgkin lymphoma. And they compared PET to circulating DNA level in this trial. And it did show that circulating DNA level is a better tool to follow these patients and to detect minimal residual disease. Impressively, 4 patients were persistently PET positive in this trial. So PET positive, but circulating DNA is negative, and they did not relapse after 3 years of follow-up. So they have PET positive, but no DNA, and they did not relapse. So this tells you this tool is better. Also, there is a patient with PET negative who progressed later on, and that patient was circulating tumor DNA positive. So it seems like it is a better tool for MRD, and hopefully more studies will be done and will become part of our standards. Can we overcome the resistance to a checkpoint inhibitor and reuse them? We've seen that we can reintroduce checkpoint inhibitor in patients who got a good response after stopping. Also, apparently, you can resensitize the patient to these by using HDAC inhibitors or hypomethylating agents. So what does HDAC inhibitors and hypomethylating agents do? They recruit T cells into the tumor microenvironment. They increase the PD-1 ligand, and they suppress the myeloid dendritic suppressor cells in the tumor microenvironment. So this is how they help into restoring the activity of checkpoint inhibitor. Here you see the study where they added hypomethylating agent, and you see the overall response rate is 75% and the CR rate is 34%. And that reflects actually the PD checkpoint inhibitor naive patients. So this is in a patient who failed checkpoint and then activity was restored by adding HDAC inhibitor or hypomethylating agent.
1 minute.
One? Okay, so this is another trial, also overcoming the resistant and reusing checkpoint inhibitor. Basically, this is decitabine used with another PD-L1 called camrelizumab. And it did show that in a patient with relapsed refractory lymphoma who failed PD-1, it can restore the sensitivity by the combination of decitabine and this PD-1 inhibitor. This is a trial that we reported from our center. This is restoration of checkpoint inhibitor efficacy after transplant. So these patients failed checkpoint inhibitors. They got allotransplanted, and then we treated them with low-dose checkpoint inhibitor post-transplant relapse, and they 5 out of 6 went to complete remission with low-dose Nivo. And here you can see their PET scans. Many other questions still unanswered, and we're looking forward for these. Bispecific T-cell engagers. There is also an NK cell engager in early phase trials. Anti-CD30 drug conjugates, PD-1 TIM3 bispecific antibody, and CD30 CAR T cells also are in trials. Also, many unmet needs still in Hodgkin lymphoma, and we're looking to answer questions for these patients, like how to deal with PET positive, inter-M PET positive patients, elderly patient, what's the best way to treat them, and patients with comorbidities, pregnant patients, what's the best way to treat them, and most importantly, a safer tool to stage them, as these patients cannot get radiation, and the staging usually done by MRI or ultrasound. With that, I will finish, and thank you.